This is Population Health Weekly. We bring the science to your street. One small habit, one clear choice. Right where real lives meet. Every voice, every choice, every truth that we share.
I am not a regular football fan, but I know that Barcelona Football Club is one of the most famous and prestigious in the world. And in March of 2017, they defeated Paris Saint-Germain 6-1, an extraordinary victory that Barcelona needed to advance in the tournament, and they did it. Massive celebrations had followed, but something extraordinary had also followed. Within months, Barcelona was drowning in debt, losing its players, and alienating its stars. For those who don't follow football at all, there is a healthcare parallel to this unintended victory of Barcelona Football Club. Back in 19th and 20th century, we've also had our own miraculous victories against infant mortality, premature death, and infectious diseases. We nearly doubled our life expectancy. But what has followed is a relentless rise in elderly populations that strains families, hospitals, and governments. While celebrating longer lives, we forgot to redesign a world ready for them. So here's the question that links a football club's downfall to a global health crisis today. We conquered disease and doubled our lifespan. So why does it feel like we're now paying the price? Very warm welcome and hello to our listeners wherever they are. I am Shahnur Azhar with Population Health Weekly. Starting today, Friday, 5th of June, I will be bringing you a key aspect of our monthly global health topic, an aspect that matters to each of us. In this month, we will be discussing the rise of the elderly, living with the unintended consequences of public health in the industrial age. In the second half of this show, we will become even more curious with our co host Erin Rogers presenting her fortnightly segment, The Triad. She has already sent me three hints to share with you this week: toys, simulators, and data. But first, let's get back to answer today's question. We conquered disease and doubled our lifespan. So, why does it feel like we're now paying the price? So, what is the price of our longer lives? I see it as having two components. One is visible, the other is invisible. Let's first touch upon the visible part that is more numeric and can be seen being extracted every day. Globally, the annual health and long-term care bill for people over 60 is projected to exceed 14 trillion euros by year 2050, more than the current GDP of all of Africa. That is a staggering number indeed. But let me give you two examples. First, from Japan, the world's most aged nation. Hiroshi is 72 years old. He is a retired factory worker and cares for his 94-year-old mother with advanced dementia. He spends nearly 70% of his monthly pension on her home care. Yet Hiroshi has to wait about 6 months for a subsidized nursing home bed. And he told a social worker that he feels guilty for resenting his own mother. Now consider Indonesia, a lower middle income country where infrastructure for long term elderly care is almost non existent. Siti is 45-year-old, a street food vendor in Jakarta who had to quit her job to look after her stroke disabled father. There are fewer than zero point 0.2 geriatricians per 100,000 older adults. Siti pays a visiting nurse out of pocket, nearly half her family's income. Her father has never had a formal blood pressure check. This is what I meant by the visible price, being seen, extracted one household and one individual at a time. Contrast this situation with that of Lionel Messi, one of the greatest footballers of all time, walking away from Barcelona when the club could no longer afford him. Siti and Hiroshi are not abandoning their loved ones, although it's incredibly hard within systems that have so far remained preoccupied with setting up information kiosks for seniors and remodeling a few urban spaces. And this visible price could be much, much steeper if one grows older without any family member around. Now turn to invisible price because numbers are only telling part of the story, and probably the smaller part. The deeper complication is that this invisible price never stands still. It shifts as disease burdens, technologies, and pharmaceuticals evolve. And then different generations feel those shifts differently. Now let's see how this plays out in real clinics with, say, internet connectivity. One geriatrician put it in a recent health system study, and I'm quoting him here. But many of my patients cannot use a smartphone. Their children have to hold the phone for them. And without reliable internet, I never get the data. Unquote. Now think about that. The price here is not just the cost of the pill or the doctor's time. It's the digital literacy gap and spotty coverage or poor coverage, a hidden tax that falls on the youngest generation, the grandchildren who become unpaid tech support. Because public health systems usually estimate the elderly care using hospital beds, medicines, and nurse hours, they miss these dynamic multi generational costs. The result? Targeted intervention, remote monitoring for heart failure, for example, underperform. Not because the medicine is wrong, but because the estimation of the true price was incomplete and static. And such estimations in low income settings could be even more complicated. So, the price that we pay in terms of public health is multidimensional, what I call visible and invisible price. It can be paid in terms of money, time, digital skills, family bonds, and bus fare. Contrast this scenario with the price of unintended victory paid by Barcelona Football Club. That price was more simpler and measurable. 1.3 billion in debt, a departed Messi, empty seats. The answer to today's question was very well summarized by Dr. Isabela dos Santos, a Brazilian gerontologist and former advisor to Pan American Health Organization. Her interview was published in 2022 in BMJ Global Health. When asked about the overall approach since population aging became a global concern back in 1990s, she answered, quote, "Every country, regardless of wealth, fell back on the same default. Informal caregiving by family members, overwhelmingly female. Globally, women provide nearly three-quarters of all unpaid elderly care. In low-income nations, that share can reach 90%. We celebrated longer lives, but we never redistributed the load. The result? Remarkable health gains alongside remarkable social stagnation." Unquote. So let me conclude by answering our today's question directly. Why it feels like we're paying the price. Because we extended human life without extending the social and economic support systems that make those extra years livable. We celebrated longer lives, but we left families, especially women, to carry the hidden costs. Lost wages, unpaid care, emotional exhaustion. That is a price, comprising both visible and invisible parts. And that is why it hurts. Important update: Barcelona is back to its winning ways, rebuilt by training young players and managing money wisely. That same idea, planning ahead, applies to healthcare too. Stay tuned for the next episode when we imagine three proverbial rings and see how they fit. And now it's time for the segment The Triad with Erin Rogers. Erin is our co-host who will bring you three updates from biomedical world each fortnight. She will be joining us in person from next week. But for today's show, she has separately recorded her segment and asked me to announce three keywords before I play her recording: toys, simulators, and data. Let's hear what Erin Rogers has sent us.
Hi, I'm your co-host, Erin Rogers, and welcome to the Triad. Effective this year, the EU, or European Union, has updated its regulations that will ban toys as soon as they are identified to contain hazardous substances. This includes chemicals that disrupt hormones, harm the lungs, cause skin allergies, or damage specific organs. Toys with small detachable parts, easily accessible button batteries, or strong magnets are known to be choking or ingestion hazards. As part of prior safety assessments, manufacturers are directed to ensure that digital toys do not pose risks to children's mental health as well. With this regulatory enactment to be completed by 2030, all toys placed on the EU market will be required to have a digital product passport containing safety and compliance information, accessible to consumers online via a QR code or other data carrier, per the Directorate General for Internal Market, Industry, Entrepreneurship, and SMEs. On the medical education front, according to FortuneBusinessInsights.com, Simulation-based medical and dental education is increasing its share in healthcare curricula, driven by a projected market growth of $7.23 billion by 2030 in medicine and over $1 billion by 2035 in dentistry. The trend is shifting toward high-fidelity, immersive, and AI-integrated training environments. A recent literature review published in BMC Medical Education concluded that simulation-based education has demonstrated statistical benefits in learning, skill acquisition, feedback, and even stress reduction. Another recent study at the University of Alicante, Spain, reported favorably on the use of simulators as tools for communication skills training in the healthcare setting. But its authors also cautioned that further research is needed to determine its long-term impact on communication skills acquisition and its effectiveness compared to traditional teaching methods. And our final update is from World Health Statistics 2025, published by the World Health Organization, or WHO. This report is subtitled Monitoring Health for the SDGs, or Sustainable Development Goals. Chapter 2 of this study presented the latest available trends in health-related Sustainable Development Goals, or SDG indicators, assessing progress towards achieving global targets. The topics covered in this chapter include child mortality, cause-specific mortality, infectious diseases, risk factors for health, universal health care, and health systems. The report is a reminder on collective action to continue reducing mortality associated with poor birth outcomes, non-communicable diseases, malnutrition, trauma and injuries, and environmental risk factors. As already well known, low and middle income countries face disproportionate mortality burden of these conditions, while being overall lesser prepared to deal with the health emergencies and pandemics they are facing.
My co-host Erin Rogers with The Triad. Technical support for this show is provided by Wahab Shahid. Podcast logo, theme music, creative and production advice is given by Imran Babar. Population Health Weekly is led by its listeners and they are invited to participate in any competent way they can. If interested, email us at info@ideas.org.s. Subscribe to our YouTube channel, Population Health Weekly, where you can post your thoughts, comments and imaginations. You can also subscribe to our monthly newsletter on our website, ideas.org.s. It's free. You can also donate to us through ideas.org.s and the hosting platform, rss.com. All contributions will be dedicated to improving the quality of this show. The transcript of this show will be available as soon as it's posted via rss.com. If Population Health Weekly sounded interesting to you, then spread the word around. Special thanks to Junta de Andalucía and Gobierno de España for their support to Autónomos that made this production possible. Tune in next week when we answer, when Grandma lives to 95, who really carries the world? Families, governments, or strangers? I'm your host, Shanu Razor. See you next Friday.